So good afternoon, everyone. My name is Gaurdia Banister, and I am the Executive Director of the Institute for Patient Care at Massachusetts General Hospital, and you will meet my colleague, Mary Knab, who will introduce herself as well. And one of the things that we think is really important as we are getting ready to share some information with you about an innovation that we are doing between both of our organizations is that it is truly an academic practice partnership. And so when we are together, we never go on the road. We never go to any conference. We never go to any presentation unless we make sure that the academic and the practice component of our work together is well represented. So we are always together. We have a team of about 10 other people that are part of this. And so we do this together as a real team. And I hope that we're going to be able to share with you some of the work that we've been able to do. In this second slide, in my opinion, so much of this has been covered in the morning. It was great to be able to come ahead of time and really hear the phenomenal speakers that you had. So we already heard about this healthcare system that is changing. We know that our population is growing older. Our patients are absolutely more complex. I do want to make a comment, however, about acute care, because our model is in the acute care environment. And while we are certainly seeing transitions in terms of ambulatory care and clinics and what's happening in the home, acute care is not going to go away. We have critically ill patients that require an intensive level of care, and we also need providers to be able to take care of those patients and families as well. It was mentioned earlier some of our challenges in terms of treating pain. We know that there are exponential costs. In fact, we are spending 50% more in terms of healthcare than any other country in the world, but our outcomes do not match that in any way, shape, or form. We also heard about value-based and that the fact that we're really looking at quality, not quantity. And our wonderful speaker in terms of engaging our patients and families, it just can be very confusing because there are just so many different role groups and we do a lot of different things. Mary and I were in a meeting at Massachusetts General Hospital probably a couple of years ago, and so we showed this slide to a group of physician educators, this committee, that has also other disciplines as well. But when we showed them all of the providers that were taking care of their patients in our facility, I think it was a little bit, in my opinion, a little bit shocking to them, all of the different disciplines that are taking care of our patients each and every day. And this probably may not even capture all of them, but look at the diversity, the difference in their educational preparation, all of them taking care of the patients along with their physician. Again, this has patient, but certainly patient and family. And again, we just thought that this was very representative of the work. So for our academic practice partnership, what we want to share with you now is what we have are what are called interprofessional dedicated education units. And this model came from us out of the nursing literature because nursing had dedicated education units, and we had them because there was a faculty shortage. And with the faculty shortage, we had to find ways that our students were going to be well educated in the practice environment. So we used our direct care providers, our frontline clinicians, as our educators. And so our chief nurse one day, when we were thinking about our wonderful partner, the MGH Institute of Health Professions, she challenged us to move beyond nursing to really look at all of the other professions that we educate. So we have our interprofessional dedicated education unit on 3 units, on 2 highly complex medical units, and 1 cardiac step-down unit. So the evolution of our model, we started off and we called it IPDEU 1.0. We had designed this experience where our students were with us for an entire semester, a half day a week. And what they focused on was not only looking at interprofessional collaborative practice and the IPEC competencies, they also were focused on their disciplinary knowledge as well. So they were looking at the importance of team and teamwork and team building, but also as nurses or PTs, they wanted to focus on their own disciplinary areas. We used our frontline clinicians, who we called clinical instructors. They were our clinicians who were actually delivering care every day. So they were current in terms of their knowledge, in terms of their preparation. So you'll see we had nurses, occupational therapists, physical therapists, and our speech language pathologists. We also had a bridge between the academic and our practice environments, and they were called CFCs. So they not only worked in the clinical environment, but they were also faculty at the MGH-IHP, and you'll hear a little bit more about that. So they helped to bridge the gap. And then at the end of the day, there would be this debriefing where they would talk about the experiences that they had, and they were in dyads. So there might be a nurse clinical instructor with two students who were PTs or OTs, or a nurse and an OT. What we found out with that model very quickly is that it was unsustainable. First of all, it was just complex trying to manage all the students. We needed to actually bring in more staff, so it was very expensive, and we knew that we weren't going to be able to afford it. We only could put 12 students through a semester, just 12 students, and that definitely was not enough. Our clinical instructors were frustrated because while they were able to teach disciplinary knowledge, they also had, for instance, an OT or a speech, and they were trying to teach them team building and the importance of teams. And then they also wanted to focus on their own discipline. We had to sort of help educate them about the importance of interprofessional collaborative practice. So now I'm going to turn it over to my colleague, Mary. One last thing. So we decided whether we were going to end this program. It was a great idea, a great experiment, or whether we were going to continue and see how we could innovate and even do better.
So it was at this decision point that I'll pick up the story. We opted for the latter option. And you see on the slide here, we kept the sort of the essence of what was really positive about the IPDEU, but we really completely revamped the model. And we could not, either of us, have done this just thinking about it from our own side. We came together, we realized that the focus really in this model, we wanted to have it be on the interprofessional aspects of care delivery. So we kept the half-day-a-week model. We significantly shortened it, though. Student dyads, interprofessional dyads, are with instructors 2 half-days a week. That's their IPDEU experience. These are early learners. They are from different disciplines. Their instructors are from yet other disciplines. The single focus, though, became interprofessional collaborative practice. And our instructors, we sort of redefined who they were. We helped them redefine themselves. And we actually changed the terminology to interprofessional practice instructor, IPIs, because that was their role. Their role was to teach interprofessional collaborative practice. We shifted the model around. They were they're the direct care providers. They have student dyads with them that they engage actively in conversation and discussion as they go in to treat each patient or provide each care delivery act that they participate in, including all of those interactions with the team. This model became scalable. It became sustainable. Our IPIs see their normal caseloads, and it's scalable. Right now, for example, compared to 12 students a semester on a unit, we're running 3 blocks, say, on an average semester, 3 two-week blocks. We can take 48 students per semester on each unit. That's 144, and we can scale that up further by adding days of the week or perhaps another unit or other blocks. We felt it was important to share with you the fact that when we talk about academic practice partnership, we actually mean that across leadership at multiple levels of our organizations. Starting from the highest level, we have the highest level support from our provost at the IHP side and senior vice president for patient care on the Mass General side. This next layer of kind of teal colored, we are Gaurdia's position is there. My position, I actually didn't introduce myself. Apologies when I started talking. My title is Director of Impact Practice at the MGH Institute of Health Professions, where I oversee a large interprofessional education initiative called Impact Practice, of which the IPDEU experience is one of those gems that really functions at that nexus of academic and practice. It functions in the practice environment. But you see that we have deans, we have our rehab directors, nursing unit directors, very involved with this, and not involved just in name only, sort of off in the background. These are the folks that sit down together relatively frequently, quite frequently, and we work together on problem solving and strategizing. Our clinical faculty coordinators cross the bridge, and Gaurdia already described them. They are the team that work now with our IPIs. They do a training program that's brief and effective. They're there with them on the front lines while the IPDEU is running, particularly in the early stages after new instructors are trained. And they support them in their delivery of education to the student dyads and in ensuring excellence in patient care, because that's really what this is about ultimately, is our patients and the care delivery. We have asked ourselves from the beginning, what impact is this having? Our IPIs and our students are where we've looked so far at data, and it was really in looking at the IPIs where we thought we were looking at what did our training program accomplish, and we stepped back and realized in analyzing the data that we're starting to see evidence that they're actually demonstrating to us in their qualitative comments and interviews that they're seeing change, they're making changes in their own practice because they are providing education on a unit that's focused on teaching interprofessional collaborative practice. And in making that visible to students on these various days when the students are with them, they're seeing even more, they're seeing how much they do and how important it is, and they're making changes to that. So again, when we say academic practice partnership, and we often put that qualifier in there of saying a true academic practice partnership, not that that adds a lot, but to us, it's not just about we're the academic institution, we need to place our students. Gaurdia and our colleagues on the hospital side are in a position to provide placements for our students. So placements do not equal an academic practice partnership. That's really clear to us, that we've got relationship in the sense of sharing values, sharing a commitment to exemplary practice and to student success. We've built leadership at all levels, and those are relationships of leaders across levels of our different institutions. We have a shared resource model. The hospital provides instructors. The Institute funds CFC time. We come together and find multiple ways in which we can figure out together what's going to work with our shared resources in a way that's cost effective and works for all stakeholders involved. And so at the end of the day, I'll just repeat one more time that primary stakeholder we're interested in the long run are our patients. I'll take just a moment to share a student quote here and one from an IPI. We've got data that's numeric, but I think this qualitative data tends to really bring it home. Our students, and this is not at all uncommon, we hear these messages all the time. So here's a student who wrote that her IPI showed us what it was like to treat patients as an SLP. But most importantly, she showed us how to be compassionate with patients and advocate for them. I felt that I learned more about patient interaction than the speech stuff. That's how she kind of summarized speech-language pathology practice. Apologies to my SLP colleagues in the room. But she said, and then went on to say it was an amazing lesson to me, that she was actually coming away having learned compassionate care delivery. A quote from one of our IPIs, in teaching, you emphasize certain elements of your practice. In the IPDEU setting, in reinforcing the rationale behind these interprofessional practices, I noticed my increased emphasis on persistence and follow-through surrounding interprofessional teamwork in my personal practice. And we've been hearing more and more of this, that our instructors are carrying this culture, carrying these values, making it visible in ways that go well beyond the hours, those mornings that they have students with them. And that's the model we were here to share. Thank you.